to present on this topic of hepatitis B and hepatitis C co-infection. I'll review a little bit about the epidemiology and testing strategies that I think we've already commented on during the past ECHO session, so hopefully some of this will be review. As a reminder, a little bit about the epidemiology of hepatitis B and hepatitis C co-infection, specifically in the United States. We know work by Dr. Gish, more recently published, has identified approximately 1.9 million people in the United States with chronic hepatitis B, and that is those defined by a detectable surface antigen. And similar magnitude, we know approximately 2.4 million people in the United States have chronic hepatitis C that is defined by detectable viremia. And of course, I would be remiss without mentioning the contributions from HIV in this triad of bloodborne pathogens. And in the United States, there's an estimated 1.2 million people with HIV. So there is, of course, a bit of overlap given the common modes of transmission for all three of these pathogens. And what we see is among those with hepatitis C, anywhere between about 1 to 6% may have evidence of chronic hepatitis B. That is defined by detectable surface antigen. When we look specifically at those with HIV, we see those percentages are not surprisingly increased and can vary significantly. Among those with HIV, approximately 3 to 13% will have evidence of chronic hepatitis B. And then among those who are triply infected, that is with HIV, chronic hepatitis B, and hepatitis C, those estimates range anywhere between 2%, most recently from an NA Accord evaluation, to upwards of 13 to 14% that we can see in the VA population. So a large burden of disease and a number of overlap with all of these infections. So how does this manifest in our clinical setting? Well, we know that the liver disease is accelerated in the setting of these co-infections, and specifically in hepatitis B and hepatitis C co-infection, we know this pathway from normal liver to inflamed and fibrotic liver to cirrhosis, and then the end-stage complications of cirrhosis, including hepatic decompensation and hepatocellular carcinoma, are increased. We know that there's more rapid development of this fibrosis, so it is accelerated. As I had mentioned, there's increased risk of hepatic decompensation among people with co-infection, and there's an increased risk of HCC. One study pointed to approximately 7-fold increased risk of hepatocellular carcinoma over mono-infections as well. And of course, in the setting of chronic hepatitis B infection, we know, owing to the oncogenic nature of the virus, that hepatocellular carcinoma can develop without first developing cirrhosis. So again, highlighting that pathway there. And then finally, we know that the presence of HIV exacerbates every aspect of this natural history of disease, increasing the risk and rapidity with the fibrosis progression. So clearly a clinically impactful dynamic with these co-infections. So what happens with these viral interactions? What we've seen is during hepatitis B and hepatitis C co-infection, it appears that hepatitis C usually dominates with regards to viral replication. And this seems to be because hepatitis C competes with and potentially inhibits hepatitis B replication. Now, arguably, these molecular mechanisms are poorly understood, and publications have been variable. There are some in vitro studies to suggest that perhaps some of the hepatitis C proteins may actually inhibit hepatitis B replication or gene expression, therefore suppressing hepatitis B viral levels. Again, there's competing data out there, so it's a little bit unclear. But what we find is that when we eradicate hepatitis C, this may allow for hepatitis B reactivation by removing those potentially inhibitory components and restoring some of the immunologic parameters that are needed for hepatitis B control. And this may manifest as increased levels of hepatitis B DNA. It may manifest as hepatitis, specifically with increased alanine aminotransferase levels, or in most severe situations may manifest as fulminant liver failure. And so this really came to light with the recent use of direct-acting antivirals for hepatitis C, prompting the FDA to release a warning in October of 2016, specifically highlighting the risk of hepatitis B reactivation among those with hepatitis C being treated with direct-acting antivirals. And in this reference here, they review 29 cases of hepatitis B reactivation among people with hepatitis C being treated with direct-acting antivirals between about 2013 and 2016. And these are all cases, this is passive reporting, so these are all cases that were reported by clinicians seeing the patients. And what we found is among those with the data available, about 13 had detectable hepatitis B surface antigen. An additional 4 patients had detectable anti-hepatitis B core antibody. And this, again, may not have had the surface antigen reported or with negative antigen. And the reactivation really seemed to develop in the 4 to 8 week period following direct-acting antiviral initiation. But there was quite a range of when these reactivations occurred, with a median of about 46 days and a range of anywhere between 2 weeks to about 28 weeks here. Now, again, the cases reported highlight that spectrum of disease with reactivation, with about 8 of the 29 reportedly clinically ill and 6 requiring hospitalization. Most significantly, with regards to morbidity and mortality, there were 3 with hepatic decompensation attributed to hepatitis B reactivation, 1 that required liver transplant and 2 that unfortunately died. So pretty severe when thinking about the spectrum of reactivation here. So these are our case reports and highlight potential risk, but what is the absolute risk, or what do we know from more observational studies? And this study here is looking at the cohort of patients, specifically US veterans with hepatitis C being treated between 2014 and 2016. So about 62,290 US veterans were identified in this time period. And only about 9 had hepatitis B reactivation. What I'll point out is that in this study, that the authors defined hepatitis B reactivation as an increase in hepatitis B DNA of greater than 1,000 international units per milliliter. And what we found is, of those with the hepatitis B reactivation, as defined by those authors, the majority had detectable hepatitis B surface antigen prior to the onset of direct-acting antivirals for hepatitis C. But we did note that 1 of those patients had evidence of isolated antibody hepatitis B, anti-hepatitis B core antibody. And so this translates among those who had the testing for follow-up, translate into about a 9.5% risk of hepatitis B reactivation among those with detectable surface antigen at the start of their direct-acting antiviral therapy course, and about 0.6% risk of hepatitis B reactivation among those with isolated hepatitis B core antibody. And so this risk is pretty significant when you think about the thresholds we use to prevent hepatitis B reactivation in the setting of, say, immunosuppression, where 10% is really a pretty significant risk and warrants hepatitis B prophylaxis. So this is one study, one patient population using or evaluating US veterans, which may have some other comorbidities, including alcohol use, diabetes, and such, that may not be generalizable to the larger population. So what other data are available with regards to identifying the absolute risk here? And what we have is a meta-analysis that examined the risk of hepatitis B reactivation during direct-acting antiviral treatment for hepatitis C. And this was a study of about 17 different studies, including about, I believe, a little over 2,000 patients, if I recall correctly. And they defined hepatitis B reactivation as greater than 100 international units per milliliter in accordance with AG guidelines here. And what they found is that there were a 24% risk of hepatitis B reactivation following DAA treatment initiation among those with hepatitis B surface antigen. So quite higher than what was reported in the VA cohort. And then among those with evidence of resolved hepatitis B, again, those with anti-hepatitis B core antibody and no detectable surface antigen, there was an increased risk, again, about 1.4% of hepatitis B reactivation in this group. So not zero, but much less than the detectable surface antigen group. And so, again, this meta-analysis identified the clinical spectrum of hepatitis B reactivation, noting that some patients may have had just asymptomatic elevations in their hepatitis B DNA. Some may have had frank hepatitis with varying degrees of alanine aminotransferase elevations. And again, in the more extreme scenario, hepatic decompensation and death could have occurred in this the setting of reactivation. So highlighting, again, that spectrum of disease with these reactivation episodes. And so what do we do in the clinical setting then with this information? Well, first, anybody coming in for hepatitis C treatment, preparing for that direct-acting antiviral therapy, needs to be screened for hepatitis B infection. And you'll likely recognize this table from prior presentations, but for the screening assays, we're really looking at the hepatitis B surface antigen, the anti-hepatitis B core antibody, and the anti-hepatitis B surface antibody. And within this spectrum, we know that those who are non-immune would have no detectable surface antigen antibody to either core or surface antibody. Thus, these people really need to be vaccinated. So that's one easy clinical intervention there. But with looking at those who have chronic hepatitis B that is defined by this detectable surface antigen, what do you do for them? Well, the first step is to really get the full profile of their chronic hepatitis co-infection. So in addition to the presumed liver aminotransferases that you likely have at your disposal, would check their hepatitis B DNA levels, hepatitis B E antigen, and the anti-hepatitis B E antibody, as well as the anti-hepatitis delta antibody, as had previously been recommended. And of note, one of the Haynes recent studies identified potentially a prevalence of about 42% of hepatitis delta in the US. So clearly important in our patient population with chronic hepatitis B. And then among those with the appropriate profiles would treat hepatitis B as per the American Association for the Study of Liver Disease guidelines. However, if you have patients who have detectable surface antigen and they're not falling into those treatment criteria nicely, what do we do with them? Well, there are really two options, and the one that we use at Penn largely is to start prophylactic hepatitis B treatment, even if they have a low hepatitis B DNA levels or undetectable hepatitis B DNA levels, again, if they have detectable surface antigen. And we continue this therapy for 12 weeks after completion of the direct-acting antiviral therapy. Another alternative management strategy that's listed as an option on treatment guidelines includes monitoring the hepatitis B DNA levels monthly after starting direct-acting antiviral treatment and after completing it as well. And with the caveats being that you would start hepatitis B treatment if the DNA levels increase tenfold above baseline or more than 1,000 international units if previously undetectable. And this is very challenging in the patient population I work with when follow-ups are often missed or irregular. So I really just aim to start prophylactic hepatitis B treatment in those with detectable surface antigen, starting direct-acting antivirals. And so what about those patients with the detectable hepatitis B core antibody, but no surface antigen with or without the hepatitis B surface antibody? Well, among those with detectable anti-hepatitis B core antibody, you could consider checking their hepatitis B DNA levels prior to DAA therapy to identify and define if they have occult hepatitis B infection, and monitor those patients for ALT rise quite closely, at least every 4 weeks while on direct-acting antiviral therapy for their hepatitis C, as well as after completing that therapy. And then initiating a hepatitis B treatment if hepatitis B reactivation occurs, again defined as a DNA level greater than 1,000, or seroreversion, i.e. a detectable surface antigen during treatment. And so in some, we know that approximately upwards of 6% of people with chronic hepatitis C also have evidence of chronic hepatitis B infection, and that the risk of hepatitis B reactivation can be upwards of 24% among those with detectable surface antigen starting direct-acting antivirals for hepatitis C. So this really should trigger all clinicians to screen everybody with hepatitis C for hepatitis B co-infection prior to a DAA therapy, and then to start hepatitis B treatment among those with detectable surface antigen when they are initiating direct-acting antivirals for hepatitis C. So I'll stop there and take any questions or clarify any issues from this presentation.